Welcome to Life by a Thousand Cuts, a podcast series about skin cancer surgery. I'm your host, Associate Professor Tony Dicker, and in each episode, we'll share practical insights to support your skin cancer surgical practice. From clinical tips and case studies to journal reviews and interviews with skin cancer colleagues. Today, we're looking at local anaesthesia doses. So let's get into it. So a couple of things for terminology first. You might have heard lidocaine or lignocaine or xylocaine. And that's effectively the same thing. So xylocaine is a brand, a registered brand name, and so the official name is lignocaine, so we can get away from a brand name. The same with adrenaline versus epinephrine, and epinephrine is the official name because adrenaline actually is a brand name. And this is just a patent thing rather than generics. So these agents, especially the lignocaine, became available in about the late 1940s. So 100 years ago, we didn't have local anesthesias as effective as the ones we have today, and therefore things were a little bit more uncomfortable than what we can do these days. This is part of the cane group of anesthetics. So there's also tetracaine, benzocaine, there's other types of these anesthetics. They're generally divided into amides and esters, and so even things like cocaine and procaine are in this group of topical local anesthesias. How do they work? So basically, these agents block the sodium channel. So when nerve signals are passing from one nerve to the next, there's a whole lot of chemicals passing between them, and by blocking these sodium channels, that blocks the function of the nerve. So what do we typically use? Our usual things are a 1% xylocaine with 1 in 100,000 adrenaline, or you can get a 1% plain. You can also get a 2% xylocaine with 1 in 80,000, so a slightly higher concentration of adrenaline, as well as a 2% plain, are the typical products available in Australia. In terms of doses we use of these, you can actually use a slightly higher dose when you're using adrenaline because the vaso slows the body, and therefore with that slower doses going through the body, and have higher doses locally without causing toxic effects. They talk about 7 milligrams per kilogram with adrenaline, 5 milligrams per kilogram without adrenaline. That roughly translates into about 30 mils of local anesthetic for a 70 kilogram person. And that's a nice number to use. If you're going above 30 mils of local anesthetic in primary care settings, you should be thinking, why am I using so much anesthetic in a outpatient setting, in a primary care setting? This is a sort of patient that probably something like some sedation would have been worthwhile in the first place. And just worth considering that as a general rule for skin cancer medicine in a primary care setting, we tend not to get near these toxic doses, but it's worth being aware of what they are and making sure we don't use very large volumes of local anesthetic. What about lower concentrations? And this is what I wanted to address today with this article, which came out in January of 2025 in Dermatologic Surgery. And they were doing a comparison of a 0.25% lidocaine, so a quarter of our 1% strength, compared to a 0.5%. So they either had half our normal strength or a quarter of our normal strength that we tend to be using in dermatological surgery. And they did a double-blinded controlled trial to see if there's any difference in its effectiveness as an anaesthesia. Now, the nice thing was basically they found no statistical difference between a 0.25% or a 0.5% lidocaine group in terms of pain score, patient satisfaction, total volumes required for anaesthesia, how often they needed to use extra anaesthetic during the procedure, and even the patient's willingness to do the procedure again if required. But the sort of things they measured, so relevant for whether these lower doses were effective or not. So yes, they found that with those lower concentrations and therefore lower total volumes, they still were able to obtain a significant and relevant anaesthetic with local anaesthesia. Now, in contrast to that, if we look at things like liposuction, where they use a tumescent anaesthetic, but they go a lot lower again. So rather than a 0.5%, they go to a 0.05%, and the adrenal is down to like 1 in a million rather than 1 in 100,000. So they're doing it at least at 10 times, 20 times dilution from what comes in those 1% vials. Now, there's a difference there because apart from very small procedures, liposuction tends to be done with either some sedation or even general anaesthesia. So it's not just for the local anaesthetic effect only. The adrenaline does help in liposuction to minimize how much bleeding occurs, but still they're finding effectiveness in very low diluted doses. Now, they talk about a very high volume of lidocaine in terms of 35 milligrams per kilogram, which is way above the 7 milligram per kilogram we're talking about, which surprises me, that statement, but it is out there published. I'd be very careful in those sort of scenarios, and we don't need to use that in our sort of scenario anyway. So there's other studies that have also shown that lower doses can be effective. Now, none of these are particularly reported on how long the anaesthetic works for. At least none of the studies I could find reported that. So I typically tell patients that the anaesthetic lasts for about an hour and a half. There's quotes for anywhere between 30 minutes and 3 hours. Whether a diluted anaesthetic doesn't last as long, I don't know, and I haven't found any studies about that. Nor have I seen any reports about different rates of complications from lower doses of anaesthetic. So these are things that are worth thinking about, but haven't been reported as far as I can find. Now, so this is showing that, yes, a diluted dose local anaesthetic can be quite effective in using smaller volumes and therefore preserving our available anaesthetic supplies, because there have been some issues in recent times. We need to consider the risk of human error. So when we're taking our vial of 1% xylocaine with 1 in 100,000 and we dilute it down, is a human involved? They've got to add something else to it. They've got to then store those new syringes somewhere. So keep that in mind, that your systems have to be really robust if you start diluting down anaesthetic, and having people aware of what actual doses are in syringes when they're drawn up, because they might be assuming different things to what's on the actual vial. So having robust systems in that circumstance. But overall, it does seem to be a very safe thing to do and an effective thing to do to preserve our supplies of local anaesthetic, which in the past have had some difficulties in our supply chain. Now, the other thing to be aware of, that in terms of those doses, that there have been deaths from getting the doses wrong. There was a case back in Sydney from 2017 where some breast implants were being, or breast augmentation was being done under local anaesthetic, and completely wrong doses of anaesthetic used, and unfortunately a death as a consequence of that. So we do need to be wary of those things as well, about potential toxic effects. And that's another advantage of the dilution, is if it's working at a lower dose, then that's worth considering because it decreases the risk as well. Look, that's all I wanted to talk about today. I hope you found this useful, perhaps even picked up something practical to use in your clinical work. A big shout out to HealthCert for all their help in production and distribution of this episode. They do a lot of good things in skin cancer education space, including helping get this podcast out to you. Thank you for listening, and I'll see you next time on Life by 1,000 Cuts.